Uh, Hello and very good afternoon, and welcome to our session on the topic Frozen Embryo Transfer. Today we have Dr. Sangeetha Anand among us to educate on the topic. She is also going to enlighten us about the topic in a very detailed manner. Also, we are pleased to have you, ma'am, as our guest. You have the stage.
Thank you for the introduction. Thank you. I'm Dr. Sangeetha Anand, consultant reproductive medicine at Apollo Fertility, Brookfield, Bangalore. Today, I would like to discuss about frozen thawed embryo transfer cycle. Frozen thawed embryo transfer is an integral part of modern day ART practice. Initially, in early part of 2000, it, 30 percentage of the cycles used to be a frozen transfer cycle. But now, because of the advantages of the frozen cycle, the number of patients having frozen transfer has increased drastically. The first successful frozen cycle was performed in 1983 by Trozen and Moher. Since then, frozen embryo transfer has contributed significantly in increasing the success rate of ERT cycles. Because of the improvement in the vitrification techniques and better understanding of the endometrial receptivity, the FET cycles have given comparable results with the fresh cycles. So they have done various studies, RCTs, where they compared the pregnancy results between the fresh cycle and frozen cycle, and they found out that the frozen cycles gives better result than fresh cycles. So I would like to discuss today about what are the indication, where do we do a frozen cycle, and what are the advantages of frozen embryo transfer cycle, and what are the various methods to prepare the endometrium. So for an implantation process to happen, there should be an interaction between embryo and the endometrium. There exists a interaction between these two. So this process is affected by three factors. One is the embryo quality, second is the endometrial receptivity, and the synchronization between these two factors. So which conditions we do freeze the embryos and do a frozen cycle. When there is a surplus quality of embryos, A grade embryos and B grade embryos, then we go ahead with the frozen cycle. When there is a poor endometrial thickness, or there is a fluid in the endometrial cavity, or when there is an endometrial polyp where fresh transfer would not give a good result, we do a frozen cycle. Second, when there is a high risk of ovarian hyperstimulation, then we do a frozen cycle. Next, when there is a high progesterone level on the day of HCG trigger, we do a frozen cycle. In fertility preservation patients who are awaiting a cancer chemotherapy or a radiotherapy, for them we do a frozen cycle. When there is a pre-implantation genetic testing on the embryos, we make embryos, do a biopsy, freeze them, wait for the genetic result, and then do a transfer. On patient request, we do a frozen cycle. And when there is a storage of donated embryos, then again we do a frozen cycle. Surrogacy program, they do a frozen cycle. So today I would like to discuss about what are the advantages of a frozen transfer cycle. As I said, cryopreserving the embryos has become an integral part of the ERT cycle. So this has dramatically increased the pregnancy rate. There is a trend towards transferring less number of embryos after a fresh IVF cycle. Plus, the improved laboratory techniques has given great results. So the success point in a frozen embryo transfer depends on matching between the embryo and the endometrial growth and selecting the proper embryo for frozen embryo transfer. Either a cleavage stage embryos in grade 1 or grade 2 or a blastocyst. If the embryos are not high grade quality, then we continue to culture till blastocyst and select the valid blastocyst for cryopreservation. The important step is settling the appropriate time for embryo transfer. Next, there should be a synchronization of the endometrium and the embryo. That's the key point in performing a frozen embryo transfer. Again, the patient needs a proper luteal base support. The age of the embryo after thawing corresponds to the age of the endometrium on the day of embryo transfer. So there are various methods to prepare the uterine lining. So it is divided into two varieties. One, A regular ovulating woman, what protocol you follow, and irregular cycle, anovulatory PCOD woman who doesn't ovulate naturally. In a regular ovulating woman, we can either do a natural cycle, which can be either a true natural cycle embryo transfer or a modified natural cycle embryo transfer. In an irregular or an anovulatory PCO woman, we can prepare the uterine lining with a hormone replacement therapy. This hormone replacement therapy can be a combination of estrogen and progesterone, or it can be a down-regulated cycle where you give GnRH agonist followed by estrogen progesterone supplementation. Next, in irregular anovulating women, we can induce ovulation with ovulogens, either letrozole or with gonadotropin injection. So, I will discuss about each and every method, what are the advantages and disadvantages. For a regular cycling woman who has been ovulating regularly, functioning ovaries, a natural cycle can be the best method. But when there is a quiescent ovary, like in a donor cycle, we need to give a HRT. HRT means hormone replacement therapy, having both estrogen and progesterone. Many infertility clinic use a mixture of many protocols. So the best method for an ovulating woman will be a natural cycle. It is feasible, natural cycle is feasible only in women who has a regular cycles and who has had a proven ovulation. That means it is confirmed that she ovulates on this day. In normal ovulating women, the protocol of choice, it is the protocol of choice because it is the simplest method, and endocrine preparation of the endometrium is achieved by endogenous hormones. It is produced from her ovaries itself. We don't have to supplement from outside. It is coming from the developing follicle. So the estrogen comes from the developing follicle. So we don't have to give extra progenova, estrogen supplement from outside. A true natural cycle, the timing of embryo transfer is determined by detecting the spontaneous LH surge. As we all know, the LH surge happens just before ovulation. So, the timing of LH surge, detecting the time of LH surge is very important in a natural cycle. What we do serial monitoring ultrasound scan, see whether the follicle is growing. So we know which day she is ovulating. So 3 to 5 days prior to her ovulation day, that is maybe from day 10 or day 11 or day 12, we start monitoring. Serial ultrasound is done where we check the follicular growth, we see the endometrial thickness, and to time the why we do this, to time the commencement of testing for LH surge. Once she crosses 15 or 17 we start checking the LH surge. LH surge can be tested either in the urine or the blood and the progesterone level. When there is a rise in the serum LH level is observed, it is assumed that ovulation will occur in the next 36-40 hours. So, LH surge in urine, but it lags up to 21 hours behind the appearance of surge in the blood. So, this is the disadvantage. The day when LH surge exceeds 180% of the baseline value, it corresponds to a day prior to the OPU or ovulation. Next is the ultrasound evidence of ovulation. So, it is little tedious to measure the LH surge, but natural cycles are the best method for regular cycling women. Next, 3 to 5 days after ovulation, frozen transfer, where depending on the stage of the embryo when it had frozen. So, the day of ovulation corresponds to the day of the egg pickup. If embryos are frozen at 72 hours time, that means 3 days old embryo, ovulation day plus 3 days is the right time to transfer. And after this transfer, in a HRT cycle, patient needs a luteal phase support with estrogen and progesterone. The advantage of the natural cycle is patient doesn't need much of medication, and it is preferred by many women because the estrogen and progesterone comes from the endogenous growing follicle. So no need to supplement too much of medication in a natural cycle. But there are disadvantages with the natural cycle. Even in women who have regular menstrual cycle, ovulation might not happen regularly. There can be associated problems with the premature spontaneous LH surge. Even before ovulation, sometimes the LH surge can happen. There can be variation in the timing of the occurrence between the cycle and between the patients. In order to assess the LH levels accurately, we have to perform sometimes even the test twice a day, which is very tedious. And LH kits might not be very accurate. It involves a risk of up to 30% false negative testing and are often reported by patients that it's being difficult to interpret the results. So that is a disadvantage of natural cycle. Monitoring the LH surge is a little difficult work in natural cycle. So what we do a modified natural cycle. In modified natural cycle, to overcome the disadvantage of spontaneous LH surge, and it becomes tedious to monitor the LH surge, we administer HCG to initiate the luteinization. How we do? Either again by natural ultrasound, regular ultrasound monitoring, or by giving a HCG injection. 5000 units is given once the follicle reaches 18 mm or 20 mm. And then we monitor at 36 to 38 hours whether ovulation has happened. So HCG administration corresponds to the HCG administration on the day of egg pickup. So as I said, ultrasound monitoring for a dominant follicle starts from day 11, day 12 or day 13. And once a dominant follicle reaches 16 mm, we keep repeating until it reaches 20 mm. Then do a blood sampling, check the LH surge. In a modified natural cycle, we give HCG trigger, and 36-40 hours later, we see whether ovulation has happened and thaw the embryos. This is the modified natural cycle. The advantage of modified natural cycle is less ultrasound evaluation is done because we administer HCG, we time the ovulation so that it is less tedious compared to a completely natural cycle. We know what time she is going to ovulate, so we can time our thawing time. But there can be an unexpected ovulation. Accurate planning of embryo thawing and transfer might not be possible sometimes, leading on to a cancellation of the cycle for up to 7 to 12%. Sometimes it is difficult in there can be difficulty in ensuring the timely thawing and embryo transfer. Next, going to the luteal phase support in a modified natural cycle. In a complete natural cycle, not much medications are required, but in modified natural cycle, the patient has to take luteal phase support. Next, going to the artificial cycle or a hormone replacement cycle. In women who have irregular cycle, HRT is best used. So what is the aim? It is the aim of this HRT is to mimic the endocrine changes happening to the endometrium in a normal menstrual cycle. As we all know, the endometrial thickness of at least 7 millimeter with a proper triple line and good vascularity is favorable for a embryo transfer, which can achieve a good result. So what happens in the follicular phase? The endometrium grows unaffected in length during the whole of the follicular phase, because with the effect of the increasing estrogen level from the growing follicle. There is no adverse effect on the reduction or the duration of exposure to estrogen. The follicular phase can be for a longer time, even it can be 18 days, 20 days. But however, the receptivity is best preserved when the follicular phase is kept between 12 to 15 days. The endometrium is affected by either incremental, it is prepared either with a incremental or with a fixed dosage of estrogen preparation, even in the supraphysiological range. How do we do? It is given by a combination of estrogen, either the oral tablet or with the transdermal patches or gels. What does it do? This estrogen, oral estrogen, it helps in the proliferation of the endometrium while it suppresses the development of the follicle by a negative feedback. When there is increasing level of estrogen in the follicular phase, it suppresses the selection of the dominant follicle by suppressing FSH. So what are all the various forms by which we use oral estrogen? Most commonly, we use oral estradiol. We start with incremental dosage. We start with 4 milligram, then make it 6 milligram, then keep increasing the dosage depending on the endometrial thickness. Next, we have transdermal patches. We have subcutaneous implants. We have gels. So what we do is in day one of the cycle, if you start the HRT, it prevents the follicular recruitment by suppressing the FSH. As I said, it's a negative feedback inhibition. Spontaneous ovulation is avoided if you start as early as day 1 or day 2 of the cycle. But if you start little late, day 3 or day 4, in a normal HRT cycle, there are chances that ovulation might occur and a premature LH surge can happen. So what is the use of progesterone? That is in the secretory phase. The aim of progesterone is to induce secretory changes in the endometrium. Again, progesterones are available as oral forms, oral tablets, injectable forms, vaginal tablets, vaginal gel, vaginal pessaries. Once the lining reaches 9 mm in ultrasound scan, the duration of estrogen exposure is not important, but the time you start the progesterone injection or the vaginal uh, suppositories are important. So, which route of progesterone administration again varies. They have found that there is no difference in the pregnancy rate between a vaginal administration and the intramuscular progesterone administration. But what they found out is the serum progesterone levels are higher with intramuscular injection, and the endometrial concentration of progesterone are better with the vaginal progesterone. So, based on this, we found out that the vaginal progesterones work better than the intramuscular progesterone. We don't need a serum progesterone, higher serum progesterone level. We just need a better progesterone level in the endometrium. So, vaginal works better than intramuscular injectable ones. Now, timing of embryo thawing and transfer. It is planned according to the moment you start the progesterone supplementation. The day the progesterone is started is considered the day of ovulation or the day of ovum pickup, and the time of thawing and transfer is determined accordingly. So, what we do from day 2, how we prepare the endometrium, as I said, hormone replacement therapy. From day 2 or day 3 cycle, we start with either 2 milligram tablets twice a day or increase incremental dosage, make it 3 times a day after 3 days. And we keep monitoring by ultrasound scan where we look at the endometrial thickness until it reaches 9 millimeter with a proper triple line and good vascularity. Then progesterone vaginal tablets are started. If you are freezing the embryos, then blastocyst, if you are planning to transfer, we do transfer on the 6th day of progesterone exposure. Or if it's a day 3 or a moruna, transfer is done on the 4th day of progesterone exposure. You need a luteal phase support with a combination of estrogen and progesterone. Whereas in a cases of amenorrhea patient, you have to induce by lutein or OC pills, then start with incremental doses of estrogen, then do a follicle monitoring, transvaginal monitoring to look at the endometrial thickness, then start the progesterone. And these amenorrheic patients, definitely we need to give a luteal phase support. So next, going to the advantages. It has got a greater control and flexibility of the timing of transfer. The cycles can be easier to plan. You can avoid Sundays, popular among many patients and their doctors. The length of the follicular phase can be variable. You can give it for 10 days, 12 days, 15 days. So cycle cancellation rates are very less in the HRT cycle. There have been higher implantation rate and pregnancy rate than patients with a natural cycle. The implantation rates and pregnancy rate are higher in patients without ovulation than ovulatory cycles. So, ovulation in a HRT cycle has a detrimental effect on pregnancy. Suppose you start the HRT on the 3rd day, 5th day, the patient might escape that FSH inhibition and ovulation might happen, or a premature LH surge might happen, which has a detrimental effect on the endometrium. So the HRT should be used in frozen embryo transfer cycles, and ovulation of the patient should be evaluated frequently during the cycles. But what are the risks involved? The administration of estrogen and progesterone does not guarantee a complete, as I said, they cannot guarantee a complete pituitary suppression. So there are some 5% chances that there might be a premature, a dominant follicle can occur, and it can lead to premature luteinization in about 5% of the cases. If a follicle undergoes spontaneous luteinization, there can be a premature luteinization. So the endometrium gets exposed to the progesterone early before we start the progesterone. So there is a change in the endometrial age. So there is an incorrect timing of thawing and transferring when there is a ovulation happening in a HRT cycle. For a cost effective perspective, this aspect is of great importance and we have to cancel the cycle. So what we do in a young patient, we suppress the ovulation with GnRH agonist co-treatment. It can be used to down-regulate the pituitary and prevent this follicular growth. So both of these protocols approach require medication and they are less physiological. But now going to the luteal phase support. If a pregnancy occurs in a down-regulated cycle, then estrogen and progesterone must be continued until placental autonomy is established, like up to 10 to 12 weeks. But there is no difference in the pregnancy rate between the different method of luteal phase support. Either you give oral or vaginal or injectable, but it requires compulsorily they need luteal phase support till the placental function is established. The use of synthetic progesterone in patients with who are undergoing IVF ICSI did lead to a higher pregnancy rate compared with the natural progesterone, micronized vaginal progesterone. Next, going to the down regulated cycle. What we do is young women who have regular ovulation, the aim is to use a GnRH agonist which will temporarily suppress the ovarian function and render the patient functionally agonadal. That means it will prevent ovulation by inducing an artificial cycle with estrogen progesterone. What we do is we give a GnRH agonist in a regularly menstruating woman on day 21 of the previous cycle. It can be either a daily dosage of GnRH agonist or a depot preparation. So after day 10, the estrogen levels are determined and then HRT is started. HRT, as I said, it is started with oral estrogens. But the disadvantages of this method is it's more expensive because GnRH agonist cost and it has few side effects, and there can be a delay in the resumption of ovulation or a periods if the FET is cancelled, because we have already suppressed the ovulation in this patient. But the cost, what are the advantages of HRT cycle compared to a down regulated cycle? In a down regulated cycle, definitely the cost is higher. Cancellation due to the luteinization occurs in 5% more of a straight HRT cycle. The pregnancy rates are almost the same in both the cycles. No difference in the pregnancy rate whether you do a straight HRT or a down regulated cycle. Now, going to the irregular cycle women, anovulatory PCO women who don't regularly ovulate. So, which protocol works better for them? What we do is we can induce ovulation. Ovary is functional, but it's anovulatory and irregular cycles. Ovulation can be induced with either letrozole or gonadotropin or clomiphene. But the disadvantage with the clomiphene is that it has an anti-estrogenic effect on the endometrium. So for ovulation, for frozen embryo transfer cycle, we prefer using letrozole. For synchronization, the day of HCG administration should correspond to the day of HCG at the administration at the source in which the embryos were retrieved. So the day of OPU will correspond with the HCG administration. So in patients with irregular cycles, letrozole is the first choice for endometrial preparation for FET. How we start? We start with a minimal dosage of 2.5 milligram from day 3 to day 7 of the cycle in order to promote single follicular development. Why we do the frozen transfer cycle? To mimic a natural cycle. In a fresh transfer, supraphysiological levels of estrogen happens. So there can be an asynchrony between the endometrial growth and the egg growth. So to prevent that, even in an induced cycle, we give letrozole 2.5 milligram only to induce monofollicular development, so that there is no multifollicular development. Then we do a follicular scan. If the follicular growth is not ideal, if it is not sufficient, then mild stimulation with 75 or HMG or 150 units of HMG is continued until one follicle reaches 18 to 20 mm. Then the ovulation is triggered with HCG 10,000 unit when the follicle reaches the criteria for a mature follicle. Meanwhile, we keep checking the endometrial thickness. If the embryos are frozen on 72 hours, that is at day 3 embryo is frozen, then embryo transfer is performed after 4 days of exposure to progesterone. Or if a blastocyst is frozen, then it is performed at 6th day. So letrozole, we usually give it a single dosage and we start monitoring from day 10 of the cycle. And if we see that the follicle growth is not that sufficient, we add a minimal dosage, either 37.5 or 75 international units of HMG injection, and until there is a dominant follicle. Once a dominant follicle or a LH surge is detected, we give an HCG of 10,000 units. And if there is still no LH surge, when the follicle is 20 to 24 mm, then ovulation is induced again with HCG. Then embryo transfer is performed after 3 days once ovulation is observed. Luteal phase support again needs HCG. As I said, we don't prefer giving clomiphene citrate because of the anti-estrogenic effect on the endometrium. So in other protocol, instead of letrozole, In anovulatory women who are very much resistant to clomiphene citrate, we can start directly with FSH injection, starting with a very minimal dosage of 37.5 to 75 international units given up to 14 days. And if no dominant follicle is recruited in a week time, the dose is then increased by 37.5 units every week to a maximum of 225 units. When a single dominant follicle reaches around 12 mm, the dosage is maintained. Then ultrasound monitored and estrogen progesterone levels are monitored. So this is how we prepare the endometrium for a frozen transfer cycle. So now it is not possible to recommend one method of preparation in favor over the other. For different set of women, whether they are ovulating or not ovulating. What was the endometrium in a natural cycle? What was the endometrium in a HRT cycle? Depending on different patient conditions, we decide the protocol. So various RCTs have been done where they compared the pregnancy rate in different cycles. There was an RCT where 633 cycles were analyzed. They concluded that cryopreserving the embryos and subsequent frozen embryo transfer results in a better outcome compared with a fresh transfer due to the better embryo endometrial quality. What are the advantages? There is no risk of controlled ovarian hyperstimulation, the no risk of ovarian hyperstimulation syndrome, and higher cumulative pregnancy rate. Definitely, the pregnancy rate are better with the frozen transfer cycle. And what happens during an OM pickup? We induce ovulation. We give injections to make multiple eggs grow. When multiple eggs grow, what happens? The estrogen level keeps increasing. It reaches supraphysiological. Supraphysiological means beyond the normal physiological dosage. In a natural cycle, what happens? Only one egg grows. When one egg grows, the estrogen level maximum crosses 150 to 200 picogram. But so our human body naturally what happens? Only one egg grows and that implants. But in ovarian hyperstimulation or in a IVF stimulation cycle, we give injections to make multiple eggs grow. So the estrogen level goes high. When the estrogen level crosses 2500, the endometrial receptivity comes down. The window period of implantation narrows down. So there is a supraphysiological steroid levels. This estrogen level is nothing steroid. So this supraphysiological high levels of steroid affects the endometrial receptivity. Plus, there is a psychological support for the patient and the clinician that even if a fresh transfer fails, we have surplus number of embryos or another set of embryos to do in a frozen transfer cycle. Less monitoring is required in a frozen cycle. And as I said, that high levels of estrogen in a fresh cycle has an impact on the endometrial quality. So that is overcome in a frozen cycle. With the advent of better embryo cryopreservation techniques, that is called vitrification, higher number of patients conceive in a post-thaw frozen embryo transfer cycle. Plus, as I said, the window period of implantation is between 19 to 25th day of the cycle. This window period is narrowed down in a stimulated cycle, in a fresh transfer, in a fresh cycle. Whereas in a frozen cycle, where the hormone levels comes down, we bring down the hormones to the normal range, and when we transfer in a frozen cycle, the patient compliance is also better, plus the pregnancy chances are also better. So now, which method, as I said, again varies patient to patient. Which method of endometrial preparation, either a natural cycle or a modified natural cycle or a HRT cycle or a down-regulated cycle, may be decided upon many factors, depending on what was the previous HRT cycle, what was the response, how did the endometrium grow in the previous cycle, and depends on number of hospital visits you plan for a frozen transfer cycle. What are the serious adverse effects and side effects of the different medicine? And it depends on the hospital and IVF lab logistics. This lab gives better results in fresh transfer or a frozen transfer, as well as the patient and the doctor preference. Any questions? I'll close this session. Thank you.